Who does the new Edwards Sapien 3? The valve-in-valve procedure that Dr. Zaks was talking about.
So we've started to do it at Mount Sinai. And I would imagine that they're doing it at the Mayo Clinic, but I can't confirm it for sure. And I'm sure that any cardiac surgery who's doing a fair amount of neuroendocrine tumor patients with a carcinoid syndrome are looking into the possibility of their interventional team doing a valve-in-valve, because they wouldn't unnecessarily want to open the chest a second time. So I think soon more and more teams will be doing it. We're doing it at Mount Sinai. I assume Mayo Clinic is doing it. And I also assume that teams around the country are gearing up to do it.
Okay. What is the test that is better than chromogranin? I think another way of phrasing that is, does chromogranin have any value at all, or is it just a last century test which has proved to be almost worthless in clinical decision making? But anyway, I'll throw that out for discussion, and then I have a few thoughts too.
So there are three groups that have published on this, at least three groups now, all three showing that the breakdown product of chromogranin A, it's called pancreastatin, that is more sensitive and specific and unaffected by proton pump inhibitors. So I routinely do it. I often do a baseline chromogranin A also to see whether they're correlating or not, but I count on the pancreastatin test.
I would like to mention there's a new multi-gene assay which is CLIA certified. It's called NETtest and has been validated in neuroendocrine tumors. Thanks to the data published in some high-impact publication, including a very recent Lancet Oncology meta-analysis, does confirm that NETtest seems to have a superior diagnostic sensitivity and specificity as compared to chromogranin. Well, the chromogranin, the bar is very low to begin with. But there is some promising data for NETtest as both diagnostic and now some data suggesting that it might even be prognostic. However, I've personally not used it, but this is a new test that we have seen coming up in last couple of years and seems to be backed by some strong data.
Right, I agree, and that's the reason I discussed it a little during my presentation as well as the sort of upcoming biomarker approach. But I think that is a major improvement. Okay, we have time for one or two more questions. Let me see what has not been asked yet. That so many people have so many questions. Let's see here. Okay, does anybody want to comment on this one? How do we determine if a tumor is receptor positive if it's non-functional, which relates to one of the tremendous confusions people have between a tumor being functional and a tumor having somatostatin receptors on it?
So, I mean,
these are, go ahead, Dr. Sasson.
No, you can go ahead. We're going to say the same thing.
Please go
ahead. By all means.
The somatostatin receptor positivity or absence of somatostatin receptor is a very distinct entity as compared to tumor being functional or non-functional. The functional and non-functional classification basically means the capacity of the tumor to secrete certain vasoactive peptides based on, for example, gastrin, VIP, somatostatin. But majority of neuroendocrine tumors are non-functional neuroendocrine tumor. That doesn't mean that the tumor would not express somatostatin receptors. The property of neuroendocrine tumor, whether they express somatostatin receptor, has to do with their morphology. What we know is the low-grade neuroendocrine tumors tend to express more somatostatin receptor as compared to high-grade neuroendocrine carcinoma. As the tumor de-differentiate, becomes more poorly differentiated, lose its neuroendocrine characteristics, it tends to lose the somatostatin receptor expression. Doesn't completely lose it. We know that high grades also tend to express some somatostatin receptor, but but it's more so seen in low-grade, well-differentiated neuroendocrine tumor. So a tumor to be functional or non-functional, it's very much separate as compared to tumor expresses somatostatin receptor or not. You can have both functional or non-functional neuroendocrine cancers or tumors which are somatostatin receptor positive or negative. So I do want to kind of make that distinction that these are separate entities.
Okay. And maybe one last question to wrap up. Is proton therapy being used to treat neuroendocrine tumors? Proton beam.
Not that I'm aware of. We will occasionally use stereotactic beam radiotherapy or IMRT for select patients, but I'm unaware of anyone using proton.
Now, proton beams are being used for treating very, very tiny tumors in very specific places, like in the back of the eyeball, something like that, where you want to have a very, very, very focused radiation uptake in the tumor and not cause much damage surrounding. There are other ways of accomplishing that type of specificity as well, but proton beams are available in a few places in the country for that very, very specialized indication. Okay, so I think that that ends the question session. There's questions keep coming in every moment, and there are other questions too. And if we could answer them individually or later, we're happy to do what we can. But I think we have to wrap up the formal question and answer session now. Thank you very much.
Yes. Thank you to all of you for spending your day with us.
Thank you.
And I do have a brief question while we get everybody from the patient panel up on the screen. If the experts could just give us their 15-second version of what is the most important thing that a new NET patient can share with you. What should they share with their physician? And if you want to start with you, Dr. Walden.
I think the most important thing is just to share their symptoms and feelings about the disease, and what often turn out to be misconceptions. It makes a big difference in people's lives if they realize that they usually have something which is extremely treatable and which is not a death sentence, but rather a chronic condition where people can live for many years with appropriate treatment, with quality life, and they can do very well. And I think that's the most important thing. Certainly patients need to share their past medical records and imaging and pathology and all the things we look at. But the thing that comes directly from a patient that you don't get from the records is the personal part, and that really makes all the difference in the world.
Great, thank you. How about you, Dr. Zaks? What are your thoughts?
So I think in characterizing their symptoms, it's important to have a dialogue for me to understand what's important. For example, if someone's having a diarrhea and they report they're having frequent diarrhea, and you ask them, well, does it ever interfere with your daily life? And they tell you no, that's very important to know. On the other hand, if they suddenly get urgency where they can't wait to get to the bathroom, they can't control it, that's also very important to know. So I think it's sort of like having an appropriate dialogue. And I think this is also the value of seeing somebody who's a member of the neuroendocrine tumor team so that they can pick up on these things and make sure that they're taken care of by the right colleague, the right specialist.
Great. Dr. Sasson, what do you think?
I would echo that. I think their understanding their quality of life, and their expectations of how they would like treatment to affect that. The 80-year-old patient who may not want to undergo a Whipple operation for a small pancreatic neuroendocrine tumor. So I think it's their expectations of what they would like for their future, and particularly their quality of life, in my mind, is probably one of the most driving things that influence their therapy and their treatment.
Wow. And Dr. Chauhan.
Well, there's nothing much left for me to add to this. What I would mention is oncology is becoming more and more technical and scientific and very data-driven. But if there is one field of oncology, that is neuroendocrine oncology, where we still need a very thorough history and physical exam skills. Because if we miss out on the historical clues, whether the patient is syndromic or not, is early sign of heart failure or not, like my previous speakers have mentioned, we are going to do disservice to the patient, and the management would be completely messed. So there's a very detailed history. The patient should not shy away from mentioning their symptom, no matter how trivial they might think they might be. They might not be actually trivial. And like Marianne always say, advocate for yourself. So I always encourage for neuroendocrine cancer patient, or for that matter, any rare cancers like sarcomas or other tumors, to seek a second opinion, to seek an expert opinion. So with those two things, I think we got most of the bases covered.
Wow. Well, great advice. Well, thank you all once again, and hopefully we'll be seeing you again soon.
Thank you.
Thank
Thank you.
you.